So today we will just go about part seven of John Murtaugh, which is basically women's health. So I wanted to get this out of the system first because in John Murtaugh most of the topics are not organized according to the system or according to the subject, as we all know. But only the OBG part, that is women's health part, is done such a manner, and pediatrics part is done that way, and dermatology and men's health is in a separate section. So I just wanted to get these out of the system first and then go up with the other topics and organize them. But and also I have mostly read John Mukta and I have annotated most of John Mukta. So that when I revise, I'll just go through the important topics. So I have done few. I'm at 91st chapter now, and I've done few chapters in this part, but I'm not through yet. So those chapters which I've done, I'll just annotate the most important um, topics or most important highlighted topics which I've read and highlighted them. So and the remaining part we'll highlight together and we'll study together. So in part seven, in women's health, we start cervical cancer screening. Cervical cancer is one of the most important topics for AMC. Part one, MCQ cited here. Australia has second lowest incidence of cervical cancer in the world as a result of National Cervical Screening Program introduced in 1991, which is half in incidence. So now it has reduced due to vigorous screening programs and early treatments. So the most common cervical cancer is squamous cell carcinoma, and these types mainly spread by skin contact during sexual activity. Genital herpes types are okay. So HPV 16 and HPV 18 are responsible for around 70% of invasive cervical cancers and 50% high grade lesions. So we consider them as the most notorious, as the most infective viruses, and genital 15 are classified as virus, and these are the most common types, right? And these are also included. These are all the strains that are included in the vaccination. So, what is the basic pathology? The focus of attention. You might be wondering if the other part is important, but it's not. I did read the entire thing and I did annotate the textbook just so that I revise it in the future. So, it's definitely, at least that's for me. I am confident that it's not, but it's not a huge deal. You may as well just go through it and you will know you'll know what works for you, right? So basic pathology. The focus of attention is the transformation zone, where columnar cells lining the endocervical canal undergo metaplasia into squamous cells in the region of squamocolumnar function. So the main place where the usually the neoplasia happens is the transformation zone, and that is the most important place. And what happens basically is it columnar cells lining in the endocervical canal, they undergo metaplasia into squamous cells lining to the squamocolumnar junction. Hence, cells from transformation zone are very important to be sampled because this is the place where we usually see cancers. So this is the transformation zone, and this is the transformation. This one. So, okay, this is the transformation zone. This is the endocervical canal, and this is where the even if you have ever done a pap smear, you can use the endocervical brush to collect cells from these particular area. We make sure that we collect cells from this particular area, as this particular area is very prone to cancers in the cervical skin. Okay, so this is the appearance of cervix and during the reproductive age and in the peri or postmenopausal age. And as we've known, this is the transformation zone, the squamo-columnar junction, and this is the endocervical canal. So there are two types of brushes. This is the cervix sampler broom or combi, which includes a spatula and endocervical brush. So we usually put it over here so that the spatula and the broom goes over here. So we'll discuss it in the later stages. And so low-grade ones usually represent an acute HPV infection, which can be seen with both low-risk and high-risk HPVs. Most women clear the virus about 10 months with no lasting effect, but persistent infection can be a type with an HPV type causes precancerous changes. That is HSIL, high-grade squamous intraepithelial lesion. HSILs, high-grade squamous intraepithelial lesions, may return to normal, persist, or eventually progress to invasive cell cancer. The average duration between HSIL and cancer is between 10 to 15 years. However, women with histologically confirmed moderate to severe request colposcopic assessment. Okay, so these are the grades of lesions, squamous intraepithelial lesions in CIN, cervical intraepithelial neoplasia. So this is a normal cell, and CIN stage 1 is where you see the cancer cells. This is where the cancer cells. CIN1 is where the cancer cells are very low to minimal, and this is almost like moderate, and this it keeps on increasing. So this is the basement membrane, and here is carcinoma in situ, and here is the neoplastic cells entering, I mean, invading the basement membrane and coming out. So in situ is confined to a particular region, whereas I mean inside the basement membrane, whereas invasive carcinoma is when the cancer cells cross the basement membrane and come out of it. So we have normal, mild, moderate, severe, and then we have carcinoma in situ, and then we have invasive carcinoma. So moderate is CIN2, and moderate to severe carcinoma in situ, invasive carcinoma in situ is CIN3, and CIN1 is mild. Okay, so what is ASCOS? Atypical squamous cells. Atypical squamous cells of unidentified, undetermined significance. Okay, so this is Ethiopia, which is seen here in CIN1 mine. So then we have LSIL. Okay, sorry. It's not. Okay, so squamous cell abnormalities and different nomenclatures. Normal is within normal limits. Atypia or reactive or neoplastic is atypical squamous cells of undetermined significance. HPV is HPV CIN grade, and LSI low squamous cell intraepithelial lesion. Mild dysplasia is CIN1. Moderate is CIN2. Severe dysplasia is CIN3, HSIL, and carcinoma in situ is CIS, HSIL, which is moderate and severe dysplasias are high grade squamous epithelial lesions, whereas HPV and mild dysplasia and are low grade. And then we have invasive carcinoma. So CIS is carcinoma in situ. So these are all the short form abbreviations. These are all the abbreviations. Many patients with cervical. These are all the abbreviations. Many patients with cervical cancer, and then a little bit they are often missed. Okay, so usually the most missed of the many patients, asymptomatic patients, symptoms could be irregular vaginal bleeding, especially postcoital or intermenstrual bleeding. This is in sexually active and menstruating women. And then there is postmenopausal bleeding, and then we have vaginal discharge. And symptoms of advanced disease is could be back pain due to meds going to the vertebra, and fatigue, because cancer, vaginal fistula. So these are the most common symptoms which, if present, could be these. Most of the symptoms are usually missed or dismissed. Changed from the 2 yearly pap smear to, okay, so in 2017, it has been changed from 2 yearly to 5 yearly. So now it is being done at 5 years. Primary HPV partial invasive, as we read, the screening test will include HPV 16 and 18, because as you know, these are the most notorious, and 12 other oncogenic types. So these are other most commonly spread viruses. So HPV types detected will have liquid-based cytology performed. So we usually use liquid-based cytology in the cervical samples. Both HPV vaccinated and non-vaccinated who should be screened. So this is very, very important. Women are invited to common cervical screening. So at 25 years or 2 years after first sexual intercourse, whichever is later. So usually the ballpark time is 25 years or 2 years after the first sexual intercourse, whichever is later. So if a woman starts, oh, okay, who should be screened? Women are invited to commence cervical screening at 25 years of age or 2 years after first sexual intercourse, whichever is later. Both HPV vaccinated and HPV non-vaccinated should be screened. An exit test should be performed at the age of 70 to 75 years. Women aged 75 or older may request screening. It is not done as a part of screening, but they can ask for screening. Screening applies only to asymptomatic women. Women with postcoital or persistent intermenstrual bleeding require co-test both HPV and diagnostic um, liquid-based cytology and referral for an appropriate. So screening applies only to asymptomatic women. So in women with symptoms such as postcoital or persistent intermenstrual bleeding, they require a co-test, that is a screening test and a diagnostic test, and referral. For women who experience first sexual activity at a young age less than 4 and who do not receive HPV vaccine before surgery, a single HPV test between 20 to 24 years of age could be considered on an individual basis. Okay. Screening in particular groups, hysterectomy. So in hysterectomy, cervical screening is still required if the cervix was not completely removed. So vaginal wart core test may be indicated if there is history of gynecological dysplasia or malignancy. So this vaginal wart core test is nothing but HPV screening and liquid-based cytology. For women, for pregnant women, cervical screening should be safely performed. So in pregnant women, we don't usually use endocervical brush or cervix brush combi as it can lead to bleeding, which may cause distress in the patient. So postmenopausal women may benefit from short course. Okay, so postmenopausal women they have vaginal atrophy due to decreased in estrogen. So before performing a cervical screening test, they could benefit from a topical estrogen ointment 3 days before the topical estrogen ointment, and which has to be applied. And this treatment should be stopped 3 days before the test. So it does not interfere with the interpretation. In immunodeficient women, such as women with HIV or single organ transplant recipients, they should be screened every 3 years, unlike in healthy women, which is screened every 5 years with HPV testing, as they are more prone to infections. Exposure to diethyl silvestrol in utero. So, an annual core test and a colposcopic examination of both cervix and vagina should be offered indefinitely. Women with abnormal vaginal bleeding, a core test is indicated and should not be delayed due to the presence of blood. So, in women with abnormal vaginal bleeding, a core test should not be delayed due to the presence of blood. Women with postcoital bleeding are present and or are unexplained in the require referral for colposcopy regardless of the result. However, premenopausal women who have single episode of postcoital bleeding, a clinically normal cervix and a negative do not need to be referred to colposcopy. Postmenopausal women with any vaginal bleeding should be referred to specialized assessment to exclude the genetic tract malignancy. Understrained populations, special attention should be paid to Aboriginal Torres Strait Islander women, as the mortality due to cervical cancer is 5 times more than that of other women in Australia. Women from cultural and linguistic diverse backgrounds, remote areas, women rural and remote areas, disabilities, experience sexual trauma or domestic violence, and women of LGBTQI community, which is gay, lesbian, bisexual, transgender. Uh, Contraception use of STI and need of STI, especially for women aged under 30 years. So for women in reproductive age, consider discussing contraception use and need for STI screening, especially for women aged under 30 years. Opportunity discussions regarding family planning, breast awareness, and breast screening are often appropriate. Some women will be highly anxious, and identifying this early allows the clinician to address fears sensitively and discuss target strategies and may help them feel more comfortable. Women with atrophy often benefit from in the immediate weeks prior to cervical screening, which has to be stopped 3 days before. Sufficient, collected, sufficient, mature. Okay, this is not important. Sufficient and a certain service to indicate that not important sample. Okay. Basically, the sample has to be done correctly, and we need to collect sufficient cell from the transformation zone is what it all talking about. And optimal timing of specimens. Okay, so yeah, this is important. You do not perform a cervical screening test during menstruation unless it is for women with abnormal vaginal bleeding, where um, the colposcopy is referred regardless of the HPV test result. And yeah, so but usually screening test is not done during menstruation, avoiding the presence of obvious vaginal infections like candidiasis, vaginosis, etc. And within 48 hours of use of vaginal frames of pessaries or solution. Communicating with the pathologist is also important, which is not important. It is actually important to include with and product changes and to include patient's age. Include about cervical. Okay, yeah. So this should be important. Verbal consent should be obtained and inquire about the previous cervical screening test as well as direct questions about intermenstrual or postcoital bleeding. And this should be done during the consultation. And pregnancy, as we all read before, cervix combi brush should be avoided and cervical brush should be avoided. Eversion, take care to sample the sperm-columnar junction. Okay, so the position, the left lateral position can be used if smears are difficult to obtain. Older women with the lax anterior vaginal wall, older women with poor hip mobility. Provides better more manipulation. Better relation. Okay, so this is the supine best position for the collection of pap smear. This is usually done for women with older women with anterior vaginal laxity or poor hip mobility. So inserting the speculum, this is Cervical ectropion is normal in most pregnant of a woman. Endocervical should be advanced until only the lower vessels are visible, then rotated quarter of rotation. Mm, this is something is important. Cancer in the sample. Okay, so management of results. So this is really, really important. So if the cervical screening test result in HPV is not detected, repeat in 5 years. If it is not detected and if the test is unsatisfactory, repeat in 6 to 12 weeks, which is 1.5 month to 3 months. A test has to be repeated in case of unsatisfactory HPV test. So, and then we have negative cytology. HPV not 6 by HPV is detected, but it is not 6 by 16 by 18, which are high risk. So, in case of negative cytology, repeat the test in 12 months. So, the cytology is okay. I mean, the cells are okay, but HPV is there, and it is not a notorious kind. So, since HPV is present, we have to repeat the test in 12 months. And then possible low grade intraepithelial lesion, we have to repeat the test in 12 months. High grade lesion, which could be severe, moderate, severe, and the invasive cancer type, as we saw before, then we should definitely refer for colposcopy. Um, and then we have unsatisfactory cytology result, which means do it in 6 to 12 weeks again. So if HPV 16 or 18 is detected, no matter the cytology result, even if the cytology result is negative or negative or unsatisfactory or LSIL or HSIL, you have to refer for colposcopy, no matter the cytology result. So no matter the liver cells are okay or there is neoplasia, whatever it is, you have to refer for colposcopy. Post treatment assessment of HSIL. So if a patient has been treated for HSIL and so the patient treated for HSIL. So she has to be checked. She has to be tested for after 12 months of the treatment to see if the treatment has worked for her or the HSIL has been cured or not. So she has, and then the patient has to be tested every year till 5 years. And if she gets negative on two consecutive occasions for the co-test, so then she can return to 5 yearly screening. Otherwise, she has to undergo annual screening. So if few women are not comfortable with the in office test. So they can go through the test by giving self-collected samples. Self-collected samples are available for women uh, aged 30 and above who have never participated in screening or overdue for cervical screening by 2 years or longer. So usually the office tests are the best test. But if the woman requests for self-collected sample, she has to be over and above over 30 years and she has never participated in cervical screening and she is overdue for cervical screening by 2 years or longer. So more than 5 years have passed and she is overdue for her screening. So these people can attain self-collection kits. If HPV is not detected in a self-collected sample, so we can advise the patient for a liquid-based cytology test. And if HPV is detected, if we can directly refer the patient for a colposcopy. Liquid sample and then cervical sample is again collected for liquid-based cytology. And then follow up according to the clinician, collected samples. HPV vaccination. This is also important. A quadrivalent HPV vaccine protects against HPV type 16 and 18, which are high risk, and type 6 and 11, which cause genital warts. This is quadrivalent HPV vaccine 16, 18, 6, and 11. Vaccination ideally occurs before first sexual activity. Currently, a nonavalent, that is Gardasil 9, which uh, is administered in National Immunization Program for males and females. It should be remembered that HPV can affect both males and females. So it has to be done, the vaccination has to be done for both males and females aged 12 to 13 years. So the nonavalent vaccine targets five additional type of oncogenic types, which are 31, 33, 45, 52, 58. And along with this, 16, 18, and 611. This is expected to prevent 90% of cervical cancers. Um, Women who have been immunized still require cervical cancer screening because the vaccine does not prevent all HPV types that cause cervical cancer. So this is important. So the women who have been immunized still require cervical screening because the vaccine does not prevent all HPV types that cause cervical cancer. So these are the references, and this somehow doesn't have summary.